Dr. Philip.
Thank you for the invitation to address you on this new and emerging topic of cementless total knees. I guess I should start by saying that I haven't converted yet, but I have done a cementless total knee. Let's see, where's the changer here? This is this one. Okay, great. Great, thanks. Okay, thank you very much. So, as we know, the cemented total knee is the gold standard. The advantages, or the survivorship, some studies show greater than 95%, 15-year survivorship, and you can restore the knee function. The disadvantage would be in younger patients. You tend to have a greater chance of bone resorption due to the high activity. You have osteolysis and possible aseptic loosening with the increased activity level. Now, for the cementless total knee, the first generation, because this has been done in the past, as I'm sure many of you know, the rationale for considering doing cementless total knees is that you can preserve bone stock, increase the survivorship in the young patient. You'll eliminate the bone cement interface, and you can decrease cement related failures. But the outcome showed that there was a higher failure rate than with cemented knees. You had osteolysis, aseptic loosening of the tibia component, screw track osteolysis, patch pore coating, and poor biological fixation. Then there was a major problem with the metal back patella as well, and with metallosis, and also at that stage, that was the earlier generations of the polyethylene, so there was those associated failures as well. Now, with the newer generation cementless total knees, the rationale remains pretty much the same. You're trying to increase the survivorship in your younger patients and decrease cement-related failures. And the outcomes in the recent paper by Kim showed that he had a 95% 10-year survivorship. So that was a significant improvement over the earlier generations. And the survivorship was equal regardless of the age, whether the patient was young or old. Now, when we speak of the newer generation cementless total knees, we're talking about the cementless total knees since 2000. Now, why is there an improvement? Well, some have hydroxyapatite that has a three-dimensional coating, which coats to the cobalt chrome beads, which allow improved fixation. And there's also the highly porous titanium, which has a three-dimensional coating, which allows better apposition to the bone. And this is a sample of one of the newer generation cementless total knees, the femoral component. And so when we're speaking of precise bone cuts, it's extremely important with your cementless total knee, as you would assume. Now, I mentioned that I haven't converted to cementless total knees, but I have done one case. In fact, the only reason or two reasons that I even considered doing it would be these recent studies showing improved survivorship. And so this is a patient that I had as a 62-year-old female, left knee osteoarthritis. And there's two things that I did here. First, she was a relatively younger patient, active, walked daily, and also she had to retain intermedullary nail. So this took I employed another one of the newer technologies that we were speaking of earlier, with navigation. And as it turns out, our hospital has 2 of these robot navigators. So this was actually a first for both, the use of the robot navigator, because I haven't bought into that one yet either, and cementless total knee. And fortunately, this is one of my smaller patients, BMI less than 35. I wouldn't attempt to do anything, any cementless total knees in my more obese patients. And this is a pre-op film. This is a retained IM nail. And the other problem is that the nail, she said, was implanted in 1985. So I knew the likelihood of finding the instrumentation to extract the lag screw would be very, very small. And here's the lateral. And this is the post-op film. It looks pretty much like your standard total knee, except for you just don't see the cement interface. And as you know, with navigation, especially with the robot, you're basing your balance on bone cuts versus soft tissue, but it still looks like good alignment. And and the other thing is I haven't converted to CR yet, but so this is a PS knee. So again, so I don't have a wide experience with the cementless total knee, so I don't have a whole lot to share with you regarding that. But it looks like that potentially may be a viable option in the future for your younger active patients, with hopefully a decreased risk of loosening. Thank you.